Hi guys, uh, can we start this instruments of cataract surgery again? Because I was not very convinced with the quality of the previous video because that was an older video and because children you all were asking so urgently. So I just put up that video which was like a year ago's and I was not well in that video. So I'm sure you didn't understand a lot of things. Okay. So, and ECCE, that was only about ECCE. So I'm going to talk about SICS today because SICS is going to have a lot more instruments, some kind of specialized instruments also you are having and some special techniques. Okay. Now, all of you know what is SICS. Come on, tell me what is SICS. Hi. All right. So the usual ones are not there. Huh? All right. Okay. So SICS is small incision cataract surgery. Yes, small incision cataract surgery. Now, what is the hallmark of SICS? It is that sclerocorneal tunnel. Okay. The hallmark of SICS is sclerocorneal tunnel. Good, Divya Bajaj. I'm so happy. Yeah, nice to see you here. Good. Good, Soham. So small incision cataract surgery, why that small incision is because of this sclerocorneal tunnel, which ensures that the incision size is very less. Okay, so the incision size is around 6 to 7 millimeter. Okay, so what you put on the sclera is 6 to 7 millimeter. All right. Okay, and the hallmark, as I again said, is sclerocorneal tunnel. I'll explain it to you. Now, to start with a cataract surgery, what you do? Okay, pre-op, you've calculated the intraocular lens power and everything is ready. Now, patient is on the table. Now, what you first do is you're going to scrub. Okay, first scrub the patient. Yes. So scrub is you use a 10% betadine. Okay, 10% betadine solution to scrub the forehead, the eye, and some people do actually the entire half of the face. It's up to them, a personal choice. So the entire area going to scrub. So please remember it's 10% betadine. Betadine is that povidone iodine. All right. Okay. So we've done that scrubbing, and then you're going to place the sheet. Okay, you're going to drape the patient. All right. So once you drape, and you will know that you'll have to expose the surgical field. All right, you have to expose the surgical field. Now for that you use a wire speculum. Okay. Now there are people who do this betadine eye drops to the eye before draping or after draping. It's again a personal choice, but before you put the incision, before you touch the eye, there has to be a betadine eye drops that has to be instilled. So that is 5% betadine. Okay, so that is 5% povidone iodine eye drops. Please remember it has to be there for 3 minutes, at least for 3 minutes. Okay, so that is the best method to prevent a post-operative endophthalmitis. Is that clear? Okay, so you're going to use 5% betadine. Okay, so povidone iodine eye drops. All right, so you put it. So I mean, that's very theoretical. Okay, so they say you put it in the inferior conjunctival cul-de-sac. Okay, so you're putting it the inferior fornix. All right, so that gets a little more theoretical because patient is lying down. You're going to just put it on top. Okay, so you put it on top and you'll have to keep it on there for 3 minutes. Now after 3 minutes, I mean a minimum of 3 minutes, right? And after that you have to thoroughly wash it because iodine, this betadine itself can lead to some sterile infection and inflammation. Okay, so you thoroughly wash it with ringer lactate or BSS because BSS is supposed to be the best solution. Okay, and then you're going to put this speculum, wire speculum. Can you see that? Can you see that clearly? Now this is called a universal wire speculum. Okay, universal wire eyelid speculum. Now why do we call it as universal? Universal because it can be used either on the right eye or the left eye. Okay, so make sure that this pointed thing is going to be, see, there is one pointed area and there is one blunt one. So the blunt one is such that, see, every measurement is beautiful. Why? See this, can you see this little bend that I'm trying to show? One second. Can you see this? Now, this area, this length, okay? Do you see this length? I'm not talking about this the horizontal, the vertical portion. Even that length is important because it is going into your fornix, no? It will go into your fornix. So you can't make something, too huge or too small. So that is the importance why you need to know about the length of the fornices. You understand? See, when you read ophthalmology, you will realize that in the textbook it will be written the length of the superior fornixes, the length of the inferior fornixes, and you'll be like, why the hell should I know all this? Now that is because somebody who's designing this and only the surgeon knows. Okay, so when the surgeon sees it's very small, it's not going to fit. It's going to fall. It's going to come off. And if it's too huge, again, it's going to fit. It's going to come off. So every measurement is important. So that is the reason why we have so many measurements in ophthalmology. Of course, thank God they're not asking you as MCQs. Okay, so this is a universal eye speculum. Yes, universal eyelid speculum, wire speculum. Why it's wire? Okay, this is the wire. I'll show you another one. Then you'll understand why we are saying it is wire. Okay. Now see, the other one that I like to use. Okay, so that's a little different. It's this one. See, this is blade. It's got this blade. Can you see the blade? And it's got a screw to retain it. You understand? So you see the difference between a wire speculum and a bladed speculum. Yes, are you able to follow, guys? See, only when you handle it, you'll know, bacha. See, I'll show you pictures again. So now you can see it clearly, no? Nivedita, can you see it? Right. See, can you see a pointed margin here? Obviously, this pointed end has to be up. It cannot face the eye. Correct? See, these are the small things that they will ask you in the exam. Just show me how to place it. Now, if you're going to place it ulta like this, where this margin is facing down, that means it's going to hurt the patient's eye. Correct? So these are the small things that examiner will expect. Now, you will think, ma'am, how will we know because we've not done a surgery? This is common sense. No, anybody will know it. Even if I'm going to ask one of my some non-medical friends, I said, yeah, will you place it on the eye? They'll be careful. Okay, so this pointed tip should not face the eye, it should face upward. Yes, so these are the small things that examiners ask you, not just UGs, even PGs at times. These are the small things, and especially when you're anxious during the exam, you don't know, you're fumbling with things, and then you're like, is it like this or should I put it like this? These are the small things, and sometimes examiners actually enjoy this fun. Okay, so now you understand why I call this as a bladed speculum, and now do you also understand why we call this as a wire speculum? The one in my left hand is a wire speculum. This is a bladed speculum. Now, what's the advantage of this bladed speculum? Now, the bladed speculum is, it will nicely keep away all the eyelashes. See, if you say I'm going to put it on my own lashes, my lashes are quite longer. So even because normally we don't cut the eyelashes for cataract surgery. So if you're going to put this, the lashes will still try to come into the field. And when you put this bladed one, it's well away from the field. Okay. So the purpose of a speculum is to keep the eyelid open so that I have a good surgical field exposure, right? I have a good surgical field exposure, correct? Especially if you're doing under topical anesthesia, patient can blink the eye, correct? So when patient can blink the eye, this is a better one than this because this can pop off. This wire speculum can pop off. Now this one has a screw also, so you can loosen it. So you can loosen it so it becomes wide, and then you insert it, and then you can tighten it. Yes? All right, clear? So this has got various names depending upon the design. And again, see what they're using in the department. If at all they're using anything like this is a Castro Viejo, okay, Castro Viejo. And there's one Baraka. At least just know the names, okay? Castro Viejo and Baraka, and this has not got any name as far as I know. Okay, and there's another one. It's just a little different, that's all. This is also a bladed one. Can you see? This is also a bladed one. Okay, bladed ones. Again, it's got, so here the screw is on the side. It's all surgeon comfort, that's all. Surgeon comfort and their experience. And here the screw is on the top. Yes, so it cannot. But Ajay Singh, बच्चा questions हिंदी में नहीं पूछा जाता है ना, तो इसीलिए first let me finish in English. If you want, I'll tell in Hindi at the end. Is that okay? Can you let me talk in English first? Because everybody is watching, all right? And questions always are asked in English, no? Just give me some time, I'll come back to you. So basic purpose of your lid speculum is to keep the surgical space, to give you surgical space. You have to see the entire cornea, and especially if you're sitting on the head end of the patient, you have to see the sclera, right? If you're planning to do an SICS. Okay. Now, what do you do next? Next is we're going to do a bridal suture. Okay. Next is a bridal suture. Please, it's bridal, not bridal, as I just said. Bridal means dulan. We are not talking about the dulan here. We are talking about bridal. Have you seen the horse? Horse ka naak mein you have that thread or that cord, no, to control its movements. Correct. So it's exactly like that. So the spelling of bridal is very, very important. Bridle. And some of the examiners are very insistent on some spellings. Like just I told you, no, Castroviejo. So they might, if at all you heard this lecture and you said Castroviejo, so the next thing they're going to ask you is what is the spelling of Castroviejo? All right. Okay. Now, now coming to, don't ask me irrelevant questions. This is only to teach. Otherwise, I'll have to just ban you from the group. Yeah. Don't distract. Just be that perfect obedient student. I would appreciate that. All right. Okay. Now coming to the next thing, bridal suture. Now bridal suture, which muscle? If you're doing it from the head end, okay. If I'm doing it from the head end of the patient, patient is lying like this, head towards me. That means I'm doing from the superior limbus side. I mean, not the limbus, on the superior side. Now there are people with a temporal approach, so they can sit temporally. Okay, this side. So they'll make the incision here. Okay, my stress ball or my smiley ball is somewhere else, so I don't have a smiley ball today to show you that. I'll show you with something else. Okay, so now let's take a personal assistant. This is my personal assistant. So you can either do it, if my patient is like this, I can either put the incision here, okay, on the superior or temporal side. So temporal means patient is going to sit, the surgeon is going to sit on the temporal aspect. So depending upon where you sit, you're going to put the bridal suture. If I'm going to sit on the head end of the patient, I'm going to put a bridal suture on the superior rectus, below the superior rectus tendon. Now, if I'm going to sit on the temporal side, then which muscle, guys? Which muscle? Any answers? I'm going to employ a temporal approach. Yes, very good, Sanya. Lateral rectus. Okay. But typically, the forceps. So this is your superior rectus holding forceps. Okay. The superior rectus holding forceps has been designed in such a way to ensure a superior rectus only. Now, why? I'll tell you why. Now, how do we normally do this? So, do you see that it is like a swan? Its neck is it's like a swan. Have you all seen the bird swan? It's got one neck and then one little. Can you all see that? Yes. Are you able to see the bend here and another bend there, like a swan's neck? Yes. Okay. So now this first bend. Now this first bend, we always keep it at the limbus. Now patient is lying down like this. So I keep the first bend at the limbus. So my second bend correctly is 7.7 millimeter ahead. Okay. So when I keep this first bend at the limbus, so that means this is 7.7 millimeter long. So designing of instruments is very important. Now you remember we always talk about what is the distance of the insertion of the muscle from the limbus. And you're like so irritated. Ma'am, why do we have to know about this? The superior rectus is 7.7 millimeter. Then the lateral rectus is 6.9 millimeter. Then the inferior rectus is 6.6 millimeter. And the medial rectus is 5.5 millimeter. You remember? So it's 7.7, 6.9, 6.6, 5.5. And why the hell should we know this? Exactly for this reason, because somebody who designed this instrument knew that. So the moment you keep here, this is 7.7 and it's going to rightly touch at the insertion point. So you grasp it and you pull it up, you pull the tendon up and then you pass a suture beneath it. You understand? So everything in anatomy, and now you people will understand why I love my first year so much, because somebody actually said, senior said, whatever you learn in anatomy, you're going to use it later in life. Okay. Probably nobody told you that. That is the reason why you curse anatomy and why are we learning all this and why are we learning all these anatomical features and why does she spend all her time talking about anatomy? That is because of, for surgical reasons. It's all got clinical implications. All right. So now, once you caught hold of this, the superior rectus, okay, you pull it up and then you pass a suture beneath that. So that will be Yes, so that will be a 40 silk or a 60 silk. So you pass that suture and bring it up. Okay, so you're going to, once you pass that suture, okay, you bring it up and you have a brow here. Okay, so let's say this is the eyebrow. So over that, you kind of, on the drape, you're going to clamp it. Is that clear? So to start with, this is what we do. So now, I'm coming to your question, beta, regarding your lateral rectus. So now, when you pull it, because there is a brow here, see, normally what you will think is, ma'am, if we pull the suture, the eyeball will move up. Na, kya faida hai? What is the benefit? Now, the purpose of bridal sutures to increase the surgical space exposure, your surgical field exposure. But because I have a brow here, imagine, see, if there is no brow, like as if I'm doing from the temporal side, if I'm going to just pull it like this, obviously my eyeball will move this side. The surgical exposure will not be there. But now I have a brow, and over that only I'm using my clamp. I've clamped it. So when I pull on this, there's now this element of fulcrum that comes in between. All of you remember physics, there's a fulcrum. So now there's a change in the vector force and sorry, not the force, the direction. So now what happens when you pull, this fulcrum is there and the eyeball will start moving down. You try it with any of your personal assistants like this, you'll know. So now if it is just my lateral approach, if I pull, it is going to come because there's no fulcrum here. Whereas for my superior thing, there's a fulcrum. So when I pull, it will automatically go down and the eyeball will depress. So see, I put already a speculum and now my eyeball depresses. Do you see the amount of exposure you have of your surgical field? You understand? Guys, clear? Okay, now for lateral rectus, you have to use a little bit of your clinical judgment because we don't really have a separate lateral rectus forceps, and not many people put a bridal suture for temporal because temporal, वैसे ही you'll have an increase. See, compared to this exposure is more. So that is one reason why people normally don't put a bridal suture when they're doing a temporal approach. Now, even if they're going to do it, just places ahead a little on the cornea, and then you get a hang of it as you keep doing it. Fulcrum thing is back to physics, and I'm not the physics teacher here, so I'm not going to talk about that. Any other doubts, guys, before I move to the second one? Shafiq, overall it's 7.7. That's an average. So sometimes you may not be able to hold it, but then with your clinical judgment, your feeling, the feeling, you'll know whether to go a little behind or, come a little forward. You'll have an idea. Sanya, I think I've answered your question. There's no different instrument, the same instrument only. You use your clinical judgment. All right. Anything else? The name of this is he's my personal assistant. Okay. So now the next step. Okay. So we put the bridal suture. Next, what do you need to do? You have conjunctiva and tenons, correct? Because now I want to give a incision on the sclera because I'm talking about SICS. So I want to give an incision on the sclera. So, but I have conjunctiva over this. So that means I'll have to cut open the conjunctiva. Now, how do I cut open the conjunctiva? Make a nick just close to the limbus, not entire conjunctiva here because I'm doing a superior approach here. So that means I need a little space here. So this area, the conjunctiva and the Tenon's capsule, we're going to cut. So for this, I need a forceps to hold it. I need a scissors to cut it. So what I use is a small limbs forceps. It's a very tiny one. Okay, limbs, LIM''S, limbs forceps. Now, there are people who use what is called as a colibri. As I already said, colibri will have a little bend. Okay, so I'll post pictures of it, right? So colibris or this limbs. Okay, most of them use limbs. That's what I've seen in my UG, I've seen in my PG, but certain areas, yeah, there is colibri. Okay, so this is a tooth forceps. Okay, so this is a tooth forceps. So that means you will have some jaws, some teeth here. So normally has one tooth on one side and the other has two, right? Okay. So why a tooth forceps? If you don't use a tooth forceps, it will crush the tissue. I don't want my conjunctiva to be crushed. Okay. So now you hold with one hand, and then, I mean, if you're you're a right-handed person, you're a left-handed person, or both, it's up to you. And this is a corneoscleral scissors. Okay. So the corneal scleral scissors, all you have to know is, see, it works by spring action. Okay, it acts by spring action. Okay, it's springy. Okay, and number two is, how does it differ from your normal scissors? See, normal scissors, if you have to open the blades, what do? You will have to pull it apart to open the blade. But here it's ulta. See, you bring this close. I'm sorry. Yeah, what do? I myself forgot. Yeah, how do you use the scissors? But that's different. This is different. Okay, so you have this Corneoscleral scissors. Yeah, ambidextrous. Correct. I was in a. Okay, so we are done with peritomy. Now, okay, now when you read your textbook, you will have a confusion. What is this peritomy? So, peritomy is cutting open the conjunctiva. Okay, and they will tell you the conjunctiva, you make a fornix based flap. Now, what is this fornix based flap? Now, I cut here, correct? So, I'm raising the conjunctiva. Now, there are people who do conjunctival and tenons dissection separately or at one go. I do separate. One go, you go deep and you'll start separating both the tenons and the conjunctiva. Now, when I say fornix based flap, that means I'm raising the conjunctiva here. You understand? Okay, so the conjunctiva, I'm going to lift it towards my fornix because my superior fornix is here. So I'll cut and then I'll open my, move my conjunctiva towards the fornix. That is called fornix based conjunctival flap, because when you read your textbook you have no clue what nonsense it is, and then you just blame ophthalmology is full of nonsense. No, we are very specific in what we're saying, except that we don't explain it to you, we just give it in one word, and you get confused. Now, because there are some surgeries where they do a limbal based flap. So limbal based flap means when you're cutting, you move the conjunctiva towards the limbus, but in cataract surgery we do a fornix based flap. Is that clear? So now when you do that, your sclera is exposed. Now sclera has some vessels, episclera has vessels, so that might bleed. Now you can use heat cautery, the ball cautery, you heat it on the flame and then place, or you can use the bipolar cautery you can use. Okay, so that's a wet field bipolar cautery. You must have seen. As the surgeon keeps placing it, the assistant keeps on putting fluid on it, right? So wet field bipolar cautery, that is also done. Okay, so you do that and your field is ready. Now what you're going to do, now you're going to make the incision. Now how do you make the incision? So incision can be done all with one instrument, or you can use two different instruments to make the incision. So there are people who do it with a blade, okay, that 11 blade, and they actually continue the entire SICS with that 11 blade. I had a friend who used to do like that. Or like most of us, what we do, we use this crescent only. Can you see this crescent? Oops, wait. Can you see the crescent? Yes, why is it called a crescent? I don't want to touch it because it will. Okay, can you see the tip? Can you see the tip of this instrument? It is, crescentic. It's not that huge. Not that huge an instrument like you see in pictures. It's such a tiny one. Okay. So with this crescent only, just ultify the crescent like this so that this touches the eye, and just make an incision. Okay. So that this tip is perpendicular to the sclera. Make sure that tip is perpendicular to the sclera. Now the incision can be, it's not a limbal incision. It is 1 to 2 millimeter away from the limbus. Okay. And you're going to make only a partial thickness groove. It's not a full thickness. Now because 1 to 2 millimeter, I make a full thickness, I will go and hit the ciliary body. Okay. I'll go hit the iris and the ciliary body. I don't want to do that. I just put a 50%, okay, 30 to 50% kind of, make that kind of a groove. So the direction, the shape of the incision. So you can make it like this, parallel to the limbus, but the amount of astigmatism will be the greatest. Or you can make a straight line incision, or you can make a frown. Frown is like ulta to the limbus. So when I see from my end, it looks like a frown, no? So I'm going to put something like this, it'll look like a frown. Yes. So you make that kind of a groove and then use the same crescent. Yes. A smile will be like this. To me, it will smile. When I always describe based on what I see, not you see. I'm a surgeon and I'm sitting here, and you put a smile parallel to the limbus, that will be astigmatism, surgically induced astigmatism will be greatest. Okay, so you got this. So now we've made a groove, and now through that groove, now insert your crescent and tunnel your way, wiggle your way inside and start making that tunnel. From where to where? Because see, 1 to 2 millimeter behind the limbus we've started. So you're going to tunnel your way, okay, in that depth, okay, through the limbus and a little into the cornea, okay, around 1 to 2 millimeter into the cornea. So basically you will have this entire area as a crescent, I'm sorry, as a sclerocorneal tunnel. Do you understand? So it will kind of be funnel shaped. It will be kind of funnel shaped because here it is 6 to 7 millimeter. No, this external scleral incision side, it's around 6 to 7 millimeter. Inside it will be a little longer. It will be 8 to 9. The corneal side will be a little longer. Only then you will have this astigmatically neutralized funnel that you will get. Okay, so you got this. Now, which is the cutting edge of this crescent? Both the tip and the sides. Okay, the tip and the sides are the cutting edges. And when we make the tunnel, we always cut when we come back, when you withdraw. You don't make a, see, when I don't know, some PGs might be watching and, you know, these are all kind of, it automatically comes when you do it, but when you describe it, okay, so the cutting motion is not when you go in. When you come back, there are swiping motions. You know the fruit slicer, that app fruit slicer, you swiping motion, you keep cutting, no? So same swiping motion you keep doing. Just imagine you're playing the fruit slicer, okay? You keep swiping. Whenever you swipe back, you keep cutting. So like that, you made the tunnel, which is the hallmark of this beautiful surgery called SICS, okay? Now, why do I say it's hallmark? Because it has shortened my incision, just 6 to 7 millimeter incision. And also when you made this tunnel so properly, there's no need to suture. It's a self-sealing one. Okay, it's a self-sealing one. And especially when we do this tunnel also, we make sure it's triplanar. Okay, what is triplanar? Yasoham, that is the external scleral incision. That is what we describe as the incision size for SICS. Now, triplanar is the first scleral groove is in one dimension, one direction. Then I'm making a tunnel in another direction. And then when you go down, dip down into the AC, because finally my incision has to lead into my anterior chamber, no? So the entry. So all are in different directions. So 1, 2, 3. So that's why it's called a triplanar in 3 different planes. All right. Okay. So we're done. I think we're going very slowly. By this time, people would have done 2 SICS or 3 SICS. Okay. Next, what do you do? Okay. I'll finish off this and then I'll tell you the little differences. Okay. So this is a keratome. Okay. This is a keratome. It's got this triangular tip. Can you see the triangular tip? Tip. Okay. So keratome is to enter into the cornea, to make the corneal incision. So you made a tunnel, right? So now you put this instrument through the tunnel and then to enter into the AC. Okay, to enter into the AC. So the last of the triplanar is through the keratome. Okay, so this is used for two things. One is to enter into the anterior chamber, and also later when you want to extend the incision, extend it internally. The internal lip when you want to extend, again keratome. Is that clear? All right. Okay. Now, what about this parasynthesis? That is your side port. Now, side port can be made with numerous things. I use this for side port. Okay. So there are people who do it with the MVR blade. Then there's another tiny blade that we have. So side port can be made with anything. Some people use a stab, just a 26G to do a stab incision. So the parasynthesis or a side port can be done initially or after creation of the tunnel. That depends on the surgeon's preference. A different size keratome based on the IOL that you're going to put, and sometimes based on the phaco probe size. Okay, so you know accurately. So this is your probe size, especially when you're doing phaco. You know, okay, so you've entered and this is your inner lip incision, so your probe will go inside. So that is the reason for the different size keratomes. Okay, so we've done an AC entry. We've entered into the AC. Okay, so once you enter into the AC, the aqueous is going to leak, so you're going to pump in viscoelastics. So there are people who use viscoelastics, or some very rarely they don't use viscoelastics, but they use just the irrigating fluid, right, to fill in the AC. Now what are we going to do? Now we are going to stain the anterior capsule using trypan blue, and then you're going to do that, what is that called? Anterior capsulotomy. So anterior capsulotomy can be done just using this 26G needle. Okay, so this 26G needle, you'll have to bend it at 2 places. Okay, so this 26G small, can you see that? thin one. So you bend it, one just near the hub and one at the tip. So that's the bent 26G cystitome. Okay, now I use an insulin syringe because that's even more thinner and even more finer. It's not scary under the microscope. I was used to that, so I use an insulin syringe. But 26G is routinely used, or you can use an Uttarata forceps. Okay, so Uttarata forceps, you're going to catch hold of the capsular edge and you keep pulling it apart. Okay, so that is your capsulorhexis or whatever you're going to do. Okay, and then this is your hydrocannula. Okay, so this will be connected to a syringe, 2 ml syringe or 5 ml syringe, and with this you're going to do the hydro dissection. Okay, so this is a thin one. Okay, so this is a hydrocannula. All right, now the question for you is, sometimes there is likely that you can get confused between this one and the one that we use for probing and syringing. Okay, I'll show you that on another video. All right, so this is a hydrocannula. Okay, so this is used for hydro dissection, hydro delineation. All right, okay, and then what do? You're going to bring out the nucleus, correct? So you can use a wire vectus. So this is actually an irrigating wire vectus, which will have 3 holes. Yes, it will have 3 holes at the tip. Okay, so it'll spurt out fluid. Okay, it'll spurt out fluid. This is connected to usually a syringe or to the IV line, no, that keeps coming. So you put it in, and then by displacement the nucleus is going to come out. Okay, so that is nucleus delivery. You can do that, or some people do it with visco, just visco expression. You push in the visco beneath the nucleus and it'll prolapse out, it's going to come out. All right, so once your I'm just doing fast forward there. Okay, so once your lens is out, I mean your nucleus is out, you have cortical aspiration to be done. The cortex is there. So for cortex aspiration, you use this Simcoe's 2-way irrigation aspiration cannula. Okay, Simcoe's. So please remember, again they might ask you the spelling of Simcoe's. Okay, so Simcoe's 2-way. Now why 2-way? Because you can see here very nicely. You can see here two things are there. 2 ways are there, 1 and 2. One where the fluid is coming in and the other the fluid is going out. Okay, so 2 ways, right? So one, usually this end is connected to the syringe and it's in your non-dominant hand. It's in your non-dominant hand for you to keep aspirating, and the other, the metallic end, that is connected to the IV line through which the irrigating fluid keeps coming inside. Is that clear? So this is Simcoe's 2-way irrigation aspiration cannula. It can be used for cortical aspiration, and sometimes, when you have a non-clearing hyphema, I'm not talking about cataract, other uses. Okay, non-clearing hyphema where you might have to do an AC wash, or very rarely for a hypopyon, non-clearing hypopyon. Okay, so we are done with that, and then you're going to place the IOL. Where's my IOL forceps? Okay, so IOL forceps is your McPherson. Where's my McPherson? Okay, so you got a McPherson IOL holding forceps, and again McPherson, it's got a little on the tip. No, you will feel some tiny spike. Okay, little tiny spike you'll see, you'll feel on McPherson. And again, McPherson, you need to know the spelling of McPherson. Okay, McPherson IOL holding forceps. You put the IOL, and then what do? You remove all the. Okay, I lost my this one Sinski's hook. Okay, I lost it. So when you put the IOL, to rotate the IOL and put it properly in the bag, you also use the Sinski's hook. Okay, Sinski's lens hook, or you can call it Sinski's IOL hook. Okay, so it is used for 2 things. Sinski's hook. One is when you want to prolapse the nucleus out, you can use the Sinski's, and again when you want to put the IOL in the bag, you want to rotate the IOL into the bag, again Sinski's is used. I lost it at the airport. Okay, so I don't have Sinski's. Then yes, of course, very good. You remove all the, somebody said, remove all the viscoelastic that you have put in, and Just fill the AC. We are done. We fill the AC with just your irrigating solution. That itself, when it forms the anterior chamber, good enough. Okay, that forms the anterior chamber. Some of us have the habit of routinely pushing in air into the AC to form the AC. Okay, a well-formed tunnel is going to close on its own. You don't have to do anything. Okay, you don't have to, literally don't do anything. It will self-seal. Now, what about the side port? The side port, you just push in a little bit of fluid into the stroma, inject a little bit of fluid into the stroma using your same, you remember that hydro cannula we had. So the hydro cannula, with that you just push in a little bit on the walls. That's it. So once you put fluid in the stroma is swelling. Why? Because proteoglycans are there, no? So that swelling itself will close that small opening. We are done. So that is SICS. Now your conjunctival flap you raised, no? So now you bring it back. Now sometimes when you just bring it back, it will oppose, or you can again use a little bit of coagulation with your cautery to oppose it. We're done. And then subconjunctival injection of dexa and some antibiotic, usually it's the gentamicin, pad and bandage, and it's over. So any doubts in the instruments for SICS, guys? These are the only instruments. Okay, nothing big, nothing much. Have I left out anything? Yes, I've kind of. Any doubts, guys? Okay, so we will have a little test. I'll post the questions, okay, in all the usual forums that I put. So on the Instagram, what? Okay, so on Insta, then that Telegram group or Facebook, everywhere I'll put up the questions. So I read up the instruments, and I hope this is useful for third years, especially because you've not been attending postings. So it's a big problem. All right. Okay, so occasional complication of visco not removed. See, the usual complication of visco not removed is there'll be a raised IOP the next day. So you'll have corneal edema. Patient will not have 6/6 vision. And the other thing is, if the thing remains behind the IOL, if you've not removed visco from the capsular bag, you get what is called as a capsular distension syndrome. So it will push the IOL forward, and you will have a big refractive surprise. Okay, so sometimes it might settle down on its own, or you might again have to go and do a little wash, remove the visco. So that's the only thing. Any other questions, guys? That's it. Okay, so we call it a day. Then I'll put up your other sessions. Okay, chalo. Bye, guys. Thank you so much.